לקדם בברכה את המרצה של הבוקר, דוקטור ג'ושוע מילנר, ואני מזמין את פרופסור עמוס עציוני to introduce you properly.
בוקר טוב. אמנם ג'וש מדבר עברית, ולכן את הפרזנטציה שלי אני אעשה בעברית, אבל לג'וש יהיה קצת קשה לתת הרצאה מדעית כולה באנגלית. לפחות ראיתם את השלט, הוא כתב בעברית. ג'וש הוא ללא ספק אחד הכוכבים העולים היום בשמי ה-NIH, אם לא הכוכב העולה בשמי ה-NIH. ג'וש את התואר הראשון שלו עשה ב-MIT, ולאחר מכן הוא התחיל את לימודי הרפואה שלו באלברט איינשטיין יוניברסיטי בניו יורק, והתמחה בילדים בבית החולים ילדים בוושינגטון, ומשם ישר הגיע ל-NIH, למעבדה של ביל פול, שהיה ללא ספק מגדולי האימונולוגים של המאה ה-20, ולמעשה לאור הצלחותיו שם נשאר ב-NIH, והיום הוא כבר מנהל מעבדה כמובן משלו. הוא מתעסק, הייתי אומר, בשילוב בין immune deficiency ואלרג'י, כאשר הוא יותר ויותר מתרכז בשנים האחרונות בסיבות הגנטיות להתפתחות מחלות אלרגיות. הוא פרסם מאמרים רבים, ביניהם מאמרים בניו אינגלנד, Nature Genetics, Nature ועוד כהנה וכהנה, ורק החודש הוא פרסם מאמר שהוא למעשה מאמר פורץ דרך על מדוע לאנשים יש את מה שאנחנו קוראים Functional Disorders, כמו Irritable Bowel Syndrome וכולי. הוא מצא את אחת לפחות מן הסיבה לכך, ומבחינתנו אולי נחמד להגיד שמי שכתב ב-Nature Genetics זה את האדיטוריאל בנושא הזה, זה חברנו אלי שפרכר. אז ללא הקדמות נוספות אני מזמין את ג'וש לבמה. ג'וש, בבקשה.
תודה לעמוס וכולם שהזמינו אותי לדבר איתכם. אני אנסה לדבר בעברית. אומרים בהגדה של פסח, או על ההגדה של פסח, שמתחילים בגנאי, בגנות, ומסיימים בשבח. אבל פה ההפך, אני אתחיל בעברית, אבל בטח שאני אסיים באנגלית. אבל להתחיל ככה. אז המחקר שלי, המעבדה שלי, מתעסק עם מטופלים שיש להם אלרגיות, אבל אלרגיות שכנראה הן אלרגיות גנטיקות. מה זאת אומרת? זה לא רק יש לי hay fever ואח שלי יש לו hay fever, אבל יש משהו שאפשר לראות שזה משהו יותר קשה, או יש בעיות אחרות חוץ מהאלרגיות או דלקות או בעיות developmental, משהו כזה, שאפשר לראות שזה לא רק אלרגיות, ויכול להיות שגן, ולפעמים גן אחד יכול להסביר מה שיש פה. ואני לוקח את המתהלך הזה משום שיש המון דברים לעשות כדי להבין את אלרגיות ולמה יש כמה אלרגיות, למה אלרגיות יש יותר ויותר אלרגיות ככה, ויש אנשים שמתעסקים בכל מיני environmental causes ככה, אבל גם כן צריך להיות שהגן יכול, אם לא להיות הסיבה, אבל להצטרף בסיבה, ואחר כך אנחנו יכולים להסביר מהמטופלים האלה שיכול להיות נדיר, אולי אנחנו יכולים למצוא סיבה חדשה שלא ידענו רק מהמחקר על המטופלים הנדירים האלו. אז אני אדבר על שלוש בעיות גנטיקות שיכול להיות שאין יותר מ-400 אנשים בעולם שיש להם את זה. אבל, סך הכל, אבל זה חשוב משום שלמדנו משהו מכל אחד ואחד שיכול להיות יותר חשוב בשביל כולנו. Okay? So, רק שנהיה באותו השטח, רציתי להתחיל להסביר את הנוגדן IgE, שזה מאוד חשוב בכמה מיני אלרגיות, זה לא כל האלרגיות צריכים IgE, אבל זה נוגדן חשוב, שיש לנו כמה נוגדנות, IgM, IgG, IgA, IgE, ואם יש IgE ספציפי נגד משהו כמו בוטנים, ככה, אם ה-IgE מעל ה-mast cell, הבוטנים יכולים to activate ה-mast cell, ככה, ומתוך ה-mast cell דברים כמו היסטמין יוצאים, וההיסטמין דברים אחרים, הם יכולים לעבוד על ה-vasculature וכמה מקומות להתחיל את ה-allergic reaction, כן? אז leaky dilated blood vessels, hives, itchiness, sneezing, wheezing, נזלת, הכל, וזה מיד, זה אחרי 10 דקות או משהו, אם יש ה-IgE ספציפי נגד האלרגן ככה. ו-IgE יכול להיות רק כמה IgE נגד בוטן, ואפשר שיהיה למישהו אנפילקסיס, וגם כן יכול להיות שיש המון IgE, אבל אם זה לא ספציפי נגד האלרגן, אז זה לא כל כך חשוב. אוקיי. אז אני מציע להתחיל עם, זה מחלה מאוד נדיר, the autosomal dominant hyper IgE syndrome, שגם כן נקרא Job's syndrome. וזה קיבל את השם את זה בבית חולים בסיאטל, אני חושב. היו כמה לימודי רפואה שמצאו שני אחות שהיו להם boils על האור, והם חשבו שהם היו בוודאי בקיאים בתנ"ך, והם זכרו את הסיפור של איוב, והם אמרו, כן, הנה Job's syndrome, והם נתנו את השם Job's syndrome, משום שהם חשבו שזה גנטי, משום שזה אחות, ששניהם היו להם אותו הדבר, והם רציתם, they wanted to trick their attending, והם אמרו, אתה יודע, אנחנו מצאנו Job's syndrome, אתה מכיר? זה היה חדש, אבל השם עדיין יש את השם Job's syndrome, אבל עכשיו אנחנו קוראים לזה autosomal dominant hyper IgE syndrome, או את השם של הגן, stat 3, נקרא stat 3. אם אתם לא יודעים, אז זה השטן פה, וזה איוב פה, זה אשת איוב פה, אוקיי. והנה כתב יד סירגוסה, כשאני מדבר עם אנשים שלא מדברים עברית, to impress them, אוקיי. בשבילכם, אוקיי. והנה, these are the symptoms in Job's syndrome, ושמתי את הפסוקים מאיוב, שהם לא ידעו שאולי זה היה יותר, זה לא רק היה בעיות עם האור, אבל הם לא ידעו את זה, הם רק ראו את הבעיות על האור, אבל כנראה ג'וב יכול להיות שזה היה בדיוק מה שהיה לאיוב, אף על פי שזה מתחיל בהתחלת החיים, לא אחר כך כמו באיוב. שכחתי לשים את הפרקים, אז יש רק הפסוקים. אם מישהו רוצה לדעת, יש לי את הפרקים גם כן, אבל לא פה. Okay, so recurrent staph skin abscesses, recurrent pneumonia and lung cysts, pneumococcal and gram-negative infections, no problems with viruses for the most part, chronic mucocutaneous candidiasis, thrush on the skin, severe atopic dermatitis, miyom rishon laleida. So it's different than typical atopic dermatitis. It's from basically the first day of life, there is this awful rash that the babies have. And actually, this was discovered in 1966, before we knew what IgE was. And 6 years later, in 1972, when IgE was discovered, an assay was performed on the blood in these patients. And so if our IgE is normally around 100 units the patients with Job's syndrome are usually 10 to 50,000 units. Extraordinarily high IgE. But in addition to the immunologic and allergic problems that these patients have, they also have problems outside the immune system, and this is one of the ways we can tell that it's a syndrome, that it's not just allergy or just infection. And so they are very hyperextendable, and their teeth stay their baby teeth stay in and don't fall out, and you have to pull them out. This is the etzba chamishi, how do you say it? Pinky, of one of the patients. And this is a panorex showing the adult teeth trying to come in, but the baby teeth not coming out. Okay. In addition, the patients can get coronary artery aneurysms and die of coronary artery aneurysms, which was something that was found only later. It's later in life. Most of these patients didn't survive, but in recent generations, we've gotten better at treating them. And as they've survived into adulthood, we've seen that almost all of them have aneurysms or tortuous arteries in the coronary arteries and elsewhere as they get older. But they have no atherosclerosis, no inflammatory disease in their vasculature, which is very, very interesting. They also have esophagitis. These psukim are amazing. I mean, it's really remarkable. They also have a very characteristic face, okay? And this is what the face looks like. It can be in any ethnicity, but the face looks very similar all the way across. They also have some autoimmune disease and a very significant increase in the frequency of lymphomas in these families. The genetic cause is heterozygous mutations in STAT3. And STAT3 is a very complicated molecule, and I'm not going to spend time explaining exactly what STAT3 does, but the important thing is what can we learn about STAT3 from this experiment of nature that has been performed. Experiment of nature that can teach us about this gene STAT3 and how can that help us in our understanding of allergy. And these are dominant mutations, so they're dominant negative mutations. As obviously people have lived long enough that they can have children as well. And so again, it's the STAT3 loss of function or the autosomal dominant hyper-IgE syndrome. One of the very interesting things about this disease, the abscesses that were seen in those two girls were very interesting because there was a huge collection of pus, but it was not hot, it was not painful, it was not swollen. So the cardinal signs of inflammation were not there in these patients. And the same is true for their pneumonias. The problem is they come in having some difficulty breathing, and when you perform a chest CT, you see bronchiectasis and pneumatoceles because it has gotten so bad because they didn't notice that they were sick. There's a problem mounting inflammation. And in addition to having a problem mounting inflammation to infections like this, they also have, as we found recently, difficulty mounting allergic inflammation. Okay, so אף על פי שה-IgE זה 100 פעמים כפולים מנורמל, אין להם אלרגיות. אין להם אלרגיות. יש המון IgE שעושה את האלרגיות, אבל אין להם את האלרגיות. למה? So that's what we wanted to learn. So we have many controls because people send to NIH patients who they think have STAT3 loss of function, but have something else. But their IgE is still very, very high, thousands and thousands and thousands. So that was our control group. And we looked for food allergy and anaphylaxis in the patients who have the STAT3 loss of function compared to controls who have very high IgE but no mutation in STAT3. And they seem to be protected from food allergy and very protected from the severest form of food allergy, anaphylaxis. And in fact, if you did morphine skin testing, did they do that here? Morphine? So they used to do as a positive control morphine skin testing because it let you know if the mast cell was working and if the response to histamine was working. And they have actually a poor response to morphine. So similar to the fact that they can have cold abscesses, they also have a poor response to forcing their allergic system to be turned on. And what we actually found, interestingly, is that the problem was not with, there may have been some problem with the mast cells. That may have been true, that STAT3 is important for a mast cell to degranulate. But what was much more interesting is that we actually made a mouse. So Hashem natan lesatan et Job, Satan natan le'Iyov et kol minei machalot. אבל ג'ון אושי שעובד ב-NIH גם כן, הוא נתן לעכבר.
אמרתי משהו לא טוב. הוא נתן לעכבר גם כן את ה-STAT3 mutation. And so when we infuse histamine into that mouse, the histamine itself, which should normally kill someone, if you infused histamine into someone, that's the mediator of bad allergic reactions, the histamine actually the mouse does not respond as much as a wild-type mouse. And so for these experiments, we look at the drop in core temperature in the mouse to see if the anaphylaxis is bad.
And in the open squares is the Job's mouse. אותו דבר קרה בחתונה שלי. אמצע החתונה שלי, האלארם התחיל. לא יודע למה. Baruch Hashem, הכל טוב. Anyway, so in Job's syndrome, the mouse's temperature does not drop as much when you infuse histamine alone. Forget about the allergy. Just the histamine alone, there was a poor response. And so actually we had the incredible opportunity at the NIH that we had two mothers who knew that their babies by prenatal testing had the STAT3 mutation. And the two mothers said, I want you to save the umbilical cord and harvest the cells from the umbilical cord. So she thought we were going to save the blood. But we also said, can we please save the endothelial cells? So the endothelial lining in the vein of the umbilical cord actually gives us an opportunity to look at what the insides of blood vessels look like in these patients. And so in the middle of the night, babies were born in two different places over the course of a couple of months, and someone drove a couple hundred miles to get the cord, drive it back, and make an endothelial cell line from these babies who had a STAT3 mutation, which is really amazing. And so what we did was a permeability assay. So what you do is you put a layer of these human umbilical vein endothelial cells on the bottom of it's called a transwell plate, and we put a dye. This looks red, but we used a yellow dye. And then we add the histamine and look to see if the endothelial cells become leaky, because that's exactly what's happening when you add histamine or when we have an allergic reaction. One of the first things that happens is our endothelial cells become leaky and the fluid comes through, and that's how we get the swelling that we get in an allergic reaction. And we looked to see if we added histamine to a control human umbilical vein endothelial cell or to the patients, would there be a difference in the response? And you can look at the color that went through. Here you have very nice permeabilization when you add histamine in the wild type, and in the two different Job's patients lines, no response to histamine, which is absolutely unbelievable. Their endothelial cells did not permeabilize at all to histamine. And so as the result, we actually worked with a person named Dave Tweardy in Baylor College of Medicine who had a small molecule inhibitor of STAT3. And we gave injections of this inhibitor to mice and then infused histamine or just gave it an allergic reaction by cross-linking IgE. And lo and behold, this small molecule inhibitor that you just gave to the mouse for a couple days before significantly inhibited that drop in temperature that you see when you induce anaphylaxis. So by studying these very rare patients with a very strange disease that's associated with some allergy, but more specifically with a very, very high IgE, and yet they were protected, we actually learned a lesson about potentially finding a medication that could be used to prevent anaphylaxis in people who have regular, everyday garden variety allergies. Okay, so there was a lesson that we could learn by studying this very rare disease, and actually we are going to be starting clinical trials in people who have severe anaphylaxis to give them a STAT3 inhibitor and see. Obviously we know what we need to monitor because we know what the disease looks like when you really have low STAT3, but it's an important drug, and actually STAT3 inhibitors are very important in the world of cancer because of the things that STAT3 can do with preventing cell division. Here, though, it may be very helpful in people who have severe allergies to prevent those allergies. And in fact, if the patients with Job's syndrome didn't have this defect in STAT3, their allergies would be far, far worse. Okay? So there was a refuah and a makah at the same time. Okay. Another extremely rare disease. Here we're talking about less than 20 people that we know of in the world who have this. It's called PGM3 deficiency. We had two different families. They had every allergy in the world. They were not protected from any allergies at all. Severe atopic dermatitis, high IgE, food allergy, asthma, eosinophilic esophagitis. Every possible allergic problem that you could have, these children had. They also had recurrent infections of all sorts, including viral. But they came to the attention of everyone not just because of their bad skin and some infections, but they also had a developmental delay as well. And myoclonus as well. And it was actually delayed visual and skin evoked potentials that these patients had. They had poor myelination is what they had. They also had some other connective tissue problems, scoliosis, and bony problems as well. If you looked in the lab, their immunoglobulins were all high, IgG, IgA, IgE, and yet they had infections, which is interesting. Some of them even had lymphopenia. They had some autoimmunity. These are two families. So this is one family from the United States. The parents were not related to each other, and this was, but you can tell this is a recessive disorder. This was a very large family of Coptic Egyptians who were highly consanguineous, as you can see, and there were two brothers and then a cousin, many different ways a cousin, who had the same presentation. And this is just to show you, you can see both the scoliosis and the severe eczema at the same time in this patient. So what causes this disease is a mutation in a gene called PGM3. Now, PGM3 is involved in glycosylation. I don't know about here, but in America, during the lectures about glycosylation was a wonderful time to catch up on your sleep in medical school. But it's an important, critically important process for development. And in fact, if you don't have PGM3, you can't even make an embryo. It's absolutely critical for development. So these mutations that these patients had are what we called hypomorphic. They are lower, but they're absolutely not absent in function of this gene called PGM3. It's a very complicated pathway, but the important thing to know is that PGM3 makes the building blocks that we have to have for the types of glycosylation, of putting sugars on proteins. Building those building blocks requires this gene called PGM3. And actually, one of the molecules that feeds into PGM3 is N-acetylglucosamine. And you can actually find, as I'll show you in a second, N-acetylglucosamine is a supplement. My father takes it for his pain in his joints, and I try to explain that it doesn't work, but he takes it anyway. And it's a supplement. You can get it. That is the substrate that's used for this enzyme that is necessary for this enzyme to create the building blocks for glycosylation. And actually, what we see is we see that the patients have lower amounts of the product of this enzyme, UDP, or downstream of the enzyme, UDP N-acetylglucosamine. It's not important what the name is. It's important to realize that this is the product of the gene that's defective. And it is low in the patients compared to the controls. But when we add N-acetylglucosamine, which again, you can buy anywhere in the United States, no problem. We don't regulate, unfortunately, supplements, so you can buy it at your 7-Eleven store right around the corner from you. When you add the N-acetylglucosamine, you actually restore the amount of product that you need to have in the cells. You actually fix the problem in vitro by just giving this supplement, N-acetylglucosamine, from these patients. And I don't know if you can see here, but this is gluten-free, so don't worry. It's gluten-free. Everybody can take it. Okay. And so actually we did a clinical trial. We've done a clinical trial of giving this product to patients with this incredibly rare mutation. Actually what ended up happening was that we improved their immune cell function a bit too much. And there was a flare of an autoimmune glomerulonephritis in one of the patients. So we stopped the study. But at least in principle, by finding this extremely rare mutation, we actually may have found the cure, or at least a path towards the cure, by looking at this incredibly complicated pathway and giving an incredibly simple biochemical solution to it. Now again, for these patients, hopefully we can find a solution. We'll see. But where I think this is important more broadly is this is a severe mutation. This causes a very severe phenotype. How many people are out there with regular allergies? Regular allergiot ragilim. I'll stick to the English. So how many of them have allergies because of problems in this pathway? And can we come up with tests to look to see if the allergy in this particular person is being caused by slightly poor glycosylation, not terribly poor glycosylation? And in such people, would supplementation of some sort, if we could figure out the right way to do it, actually improve their disease? This is the beginning of how we try to find inroads into understanding allergy, into understanding specific, actually personalized medicine ways of treating, of managing allergies. Okay. The last example that I'm going to give you is something brand new. It's not published, and something we really just found. And this case is where the patients had, the first 3 patients we saw had bad allergy, bad atopic dermatitis, eczema, but that was it. They maybe got a little bit of super infection on their skin, but they did not have hardly any other problems, just a bad allergy. One of them didn't even have any infections in his skin until he was 13 years old. He just had bad allergies, and he was referred to the doctor because the IgE was incredibly high, tens of thousands. And then we began to look in some other patients, and some of them did indeed have pneumonias and some other infections, although again, they had children, it wasn't severe, it wasn't killing anybody. And most of them, as they got older, the allergy and the infections got better on their own. Okay? And so you could imagine that in a clinic, you might find someone who says, yeah, when I was young, I had all of those problems, but I grew out of them and I forgot all about it. But now, why does my son have eczema? Right? We hear this all the time. The patients never think about the fact that maybe they don't want to think about the fact that maybe they gave the child the eczema. But this you could see in your primary care clinic even, in some cases, this type of a presentation. So we saw multiple families, 4 different families with this presentation. And we actually were somewhat interested in this type of a presentation because there's a mouse program in Australia where they expose to mutagen and look for specific mutations. The way that humans are all the time, they look to see, it's called ENU mutagenesis, and they look for certain phenotypes in mice that develop spontaneous mutations because they were exposed, their colony was exposed to a mutagen, and they look for phenotypes. So in this case, they looked for bad allergic disease, and they found a mutation in a gene called KARMA1, or otherwise called CARD11, that caused bad allergic disease, but almost nothing else. So this has always been of interest to me. Where is the patient who has this type of mutation? And in fact, in these 4 families, what we found, even though it was a dominant inheritance, the mouse was homozygous. You had to have both mouse parents had to have the mutation, and then the baby mouse carried both mutations, had the disease. In these humans, we found heterozygous, dominant, but dominant interfering, dominant negative, CARD11 mutations in different places in the gene. And so that was very exciting because the mouse looks just like what these patients looked like. And some had infections, and some absolutely did not. And some grew out of it and looked completely asymptomatic when they presented to their doctor. The parent was asymptomatic. By the time they presented to the doctor, they were sicker when they were younger. It's not important exactly how well, to me it's important, but for these purposes, what CARD11 does, one of the most important things CARD11 does is to bring glutamine into the cell. Glutamine that you have in your diet all the time, the amino acid glutamine, to bring it into your cell and activate a pathway called mTOR, which is the rapamycin target, which is very important in the immune system for normal differentiation, normal immune function. You need that glutamine to get into the cell, and CARD11 is critical for bringing that protein into the cell. And so we wondered if there is a mutation in CARD11, it's mild, it's not all the way destroying CARD11. What if we just add exogenous glutamine? We put more glutamine in to make it easier to import the glutamine. Could that change any phenotypes? And that's what we see is, first of all, if you look at healthy controls, these are just their proliferating T cells. You see that the patient's T cells cannot proliferate normally. But if we add glutamine, suddenly we have restored quite a lot of that proliferation just by adding a simple amino acid glutamine. And this is actually something to think about. Our patients are not getting good protein intake when they have bad allergies because they're avoiding every food that you could possibly imagine, every protein source that you can imagine. And so perhaps the variability that we see is a dietary variability in the amount of glutamine that the patients are taking. Okay, so I've tried to give you 3 examples: a disease associated with infection and IgE, a mutation in STAT3. The STAT3 we now know is critical for histamine responses and created a drug target for bad allergies of all sorts. A glycosylation disorder, which seems incredibly complex, opened up a particular pathway to perhaps help us understand allergic disease of all sorts, and also potentially the intervention. And then finally, a dominant mutation in a signaling protein, this time CARD11. It can lead to severe allergy, but it can look like regular allergy. And that defect is potentially correctable by giving glutamine orally. And so we also are writing a protocol now to give glutamine to patients who have mutations in this pathway. Just to think about, you know, should we study these rare diseases? Are they just the tip of the iceberg, or are they Yosemite Claw? Are they completely different? And it's something I always worry about. That's what keeps me awake at night, that and the jet lag from last night. But it's important. And the other question that we always wonder as well is, are we seeing these genetic diseases now because we're more westernized? We didn't realize that these were genetic diseases of allergy until we became more westernized. And with our Western diet and our Western behavior, do they now look like genetic diseases of allergy because we've had the environmental interaction that didn't exist before? Okay, so these are the many folks to thank: John Lyons in my lab, and Chi Ma in my lab, who did a lot of the work, many of our collaborators at the NIH and elsewhere. This is my gang when it was warmer in Washington on the Billy Goat Trail. And toda rabba lachem.